And you are recorded.
All right. Well, good morning, everybody. This is Andrew Cole with East Orlando Chamber of Commerce, and we have one exciting presentation today that I've never done live like this, but we are getting back to business with Orlando Health, and we're getting a behind-the-scenes tour of their facilities. We're going to be getting a chance to look at some different areas of ORMC that most people probably don't get a chance to see unless if they are in urgent care or trauma care. But I want to welcome and introduce just real quick a couple of people that are going to be on here. We've got Dr. Chad Smith, who is going to be up here and saying, and with that, he is the Program Director, Surgical Clinical Care, Critical Care Fellowship, Director of ORMC Surgical Intensive Care Units, Director of ORMC Respiratory Therapy Department. We'll have Luis Herrera, Dr. Luis Herrera, who's Chairman of ORMC Thoracic Surgery, and Medical Director Rod Taylor of the Rod Taylor Thoracic Care Center at Orlando Health UF Health Cancer Center. We'll have Dr. Marshall Kress, who is the Vice Chairman of ORMC Neurosurgery, and Dr. Kaylee Walker with a cardiovascular surgeon and member department. But I do want to do one quick, real quick shout out to our trustees: Advent Health, Avalon Park, Avalon Insurance Services, Duke Energy, Fairwinds Credit Union, Great Florida Insurance, the Orlando Law Group, Orlando Health, of course, and Suburban Land Reserve. And without further ado, I'm going to hand this off to Dr. Smith here to kind of take us there if I've got us set to go. So have at it, and I will check in with you later, and we'll have Q&A. Please put those in the chat boxes if you have some questions, and we'll get to those at the very end of our presentation.
Hi, Andrew. This is Carlos Carrasco. I'm actually going to jump in right before Dr. Smith and kind of do an overview of ORMC. So my name's Carlos. I'm the Vice President of Operations and Chief Operating Officer for ORMC. Doing something I haven't done before either, which is do a live webinar and virtual tour from our helipad. So I'm going to kick us off here, and just to give you a little idea of our flight program, we have 3 helicopters in the region. This is kind of the moving front door of ORMC, whether it's our trauma program or our stroke program or our cardiac program. And we cover over a 100-mile radius. We are the only scene helicopters in the region, so that means that we can land where there isn't an airport if a patient needs us. And we're a fairly high volume program. We're doing about 120 to 150 flights on a really busy month. And also at the same time, transferring 6,500 transfers in 2019 into ORMC. What it does is it allows us to bring the services to our patients out in the community, and our team of medic, nurse, and pilot show up, whether it be in a facility or another location, or at a scene, to be able to provide the highest level of mobile care possible. As Andrew mentioned, these are unprecedented and challenging times. We're adapting to them here at ORMC. We've changed a lot of our operations in the world of COVID to be able to have quarantine units, to have pre-procedural testing, employee screening, and masking. If you're wondering why I'm not wearing a mask, I'm 6 feet away from my colleagues, and making sure that we're providing a safe environment for our teams and our patients, so we don't have to delay any necessary care. So as we thought through how do we engage with our community and look at our how we connect with folks, we realized that we can focus on those things that we can't do, or we can focus on some things that we can do that are different. It's very hard to step out here. Come on. Sorry, my glasses fogged up. So it's always hard to be able a behind the scenes tour with a big group of people. So we thought it might be a unique opportunity for us to show you guys a little bit of ORMC. And we'd start off here on the helipad, where some of our sickest patients come in from. We had to start inside the transfer center because we had a team landing as we started the call. So anyway, you'll see a lot of what we do across our campus. It's a fairly large campus with 898 beds. Our scope covers pretty much all of the adult tertiary care services. We also on this same campus have a pediatric program at Arnold Palmer Hospital for Children and Winnie Palmer for Women and Babies, the Winnie Palmer Hospital right across the street. So specialties that we offer here at ORMC, we have advanced oncology programs, cardiac programs, we have neurosciences, neurosurgery, spine, orthopedics, and then trauma and general surgery. We've got, as a regional provider, we've got the ability to really be able to provide those higher end, more complex services that actually Dr. Smith will comment on a lot. We're really excited to come out to the east side of town and be able to be a bigger part of your community. As many of you know, we're already out there with our physician practices. Our physician group is fairly large at this point with over 750 physicians in Central Florida, almost 1 million square feet of clinics, and providers out on the east side with strong primary care, women's health, and heart health providers in the region. Located out in Avalon, Waterford Lakes, and Hunters Creek, and expanding as the needs of the community change. So our next entry into bringing Orlando Health as a Choice out to the east side of town is our Randall Park freestanding emergency room, which will be opening in April or May of next year. We're really excited to do that. We want to come out and make a difference and give a little bit easier access to Orlando Health out on the east side of town. So with that, we're really thrilled to be able to give you this behind the scenes tour. Thank you for being a part of our first time doing this, and we look forward to your feedback. With that, I'll hand it over to Dr. Smith and let him take it away. Chad, you're on.
Smith. Okay, thanks, Carlos. Good morning. My name is Chad Smith, and I'm, as Carlos said, I'm the director of care of the trauma surgeons here at ORMC. And basically, I wanted to kind of take you through what someone being brought here to the trauma center might go through. They might either land on the helipad that Carlos was just on, or they may be brought into the ambulance bay here. As you can see, I'm standing, which is right outside of our emergency department. And we'll kind of tour through the emergency department and the trauma bay. Here you can see our decontamination bay, which is where somebody that might have gasoline spilled upon them or some other kind of chemical before they go into the emergency department. That obviously could promote a hazard to the emergency department. They have to be decontaminated and irrigated. You can see the hoses over there to clean the patients off. And then as we travel into the emergency department, I'll go ahead and hopefully you'll be able to hear me. But basically, this is our central desk area where patients come in. We have communications with all of the emergency departments around Central Florida. All of our emergency departments, all other emergency departments. You can see this kind of green. Most everything is green on that monitor there. That basically shows the status of the emergency departments across the region, where we can kind of communicate and coordinate as a system, and as to be able to, if there were a mass casualty event or something, to be able to coordinate with other emergency departments across the region. Stepping on in here, we have our trauma resuscitation bay, which is currently empty. But as you can see, we have 5 bays here, and at any given point in time, we can care 5, 6, 8 patients at one point in time. And basically what being a trauma center means is that we are prepared for life-threatening emergencies, injury, illness, etc. at a moment's notice. So if a trauma alert, that's what we call it, was to come in right now, I'm actually on trauma call today. So myself, emergency department physicians, surgical residents, emergency medicine residents, nurses, respiratory therapists, radiology techs, chaplains, all of us will be here, probably about 15 people for one patient. And we would be ready to provide life-saving care, basically whatever the problem is. That's what a level 1 trauma center does. and we are Central Florida's only level 1 trauma center. Another benefit of having a level 1 trauma center is that you have to have an in-house general/trauma surgeon that spends the night in the hospital. So I'm on call tonight. I will stay here all night and take care of whatever is needed of me. And so that enables us to provide other services such as advanced neurosurgery, advanced thoracic surgery, which Dr. Herrera and Dr. Carrasco will talk to you about. We also, obviously, advanced general surgery or emergent general surgical emergencies can be taken care of, 24/7. No one should have to wait for obviously for an emergency. Some of the other things we have are new. We have some of the things that require these patients require emergent blood transfusion, and we actually have in this cooler down here 6 units of what now we have. We just opened a new program where we have whole blood, which is basically basically it's a unit of blood with everything in it, not just red blood cells, but that is life-saving for our patients, and we just pull it out of the cooler and give it to the patients because it's O-negative blood, and that is a very vital resource. And I will put in a little plug for One Blood so that we can, encourage people to donate blood because our community needs it. Also here at Orlando, or at ORMC, we have a very robust Da Vinci robotics program, which Dr. Herrera will talk about as well. But we also we have basically one of the broadest service lines. We have urology, thoracic surgery, general surgery, bariatric surgery, gynecologic oncology. We all use the Da Vinci robot to take care of patients. We also have opened up that service line for acute care surgery, which is acute and trauma is what I do. So, for cholecystectomy, for taking your gallbladder out, appendix, colon surgery, we're able to offer that minimally invasively as well, on a 24-hour-a-day basis as well. So that is basically the sum of the trauma bay, the emergency department, and all the services we offer, basically at a moment's notice to provide the care that our citizens need. I'll send it back to you, Carlos, maybe, to you, Dr. Herrera.
Yeah, here. Thanks, Dr. Smith. Appreciate that great overview of our trauma program. Dr. Herrera, I think you are up next to talk to us a little bit about our oncology program and our robotic surgery program.
My name is Luis Herrera. I'm a thoracic surgeon here at Orlando Health at the Cancer Program, and I'm honored to give you a sneak peek into our operative services. So, as a cancer program, we offer a comprehensive center of excellence approach to our cancer patients. So we have a 25-year history in town providing state-of-the-art care from chemotherapy, radiation therapy, including proton therapy, which is the latest technology, and high-end surgical services, which is what I would like to share with you today. So we offer anywhere from oncologic or cancer care to reconstructive care with our breast plastic surgery team, so the patients get under one roof all the services that they need to survive their cancer journey. So we're currently in one of our operating rooms. We have 24 operating rooms at Orlando Regional, pretty busy place. As you heard from Dr. Smith, ranging from trauma, cardiovascular services. We're currently in a cardiovascular operating room, and you're going to hear from Dr. Walker, one of our cardiac surgeons, in a little while. So all the rooms are state-of-the-art. All the facilities are latest technology, excellent anesthesia support. So the focus is safety and providing you a good recovery. And that leads us into our investment in robotic technology. We're one of the busiest robotic programs in the country, right behind Mayo Clinic, believe it or not. We're number 3rd in the country in terms of volume and outcomes. So we have a total of 14 robotic systems in the system. What that means is working with intuitive surgical and the Da Vinci robot, surgeons can perform less invasive procedures with better outcomes, less complications, and a quicker recovery for patients to return to their duties. So we perform about 5,000 robotic operations here at Orlando Health, about 1,500 of those at our Orlando Regional, where we have 4 state-of-the-art robotic systems called the Da Vinci Xi. And we perform robotic procedures anywhere from lung surgery, which is what I do, bariatric or weight loss surgery, head and neck surgery, colorectal surgery, and general surgery such as hernias and gallbladders and things like this. So we're very proud of our program. We look at our outcomes regularly and make sure that they're up to what we expect, and we plan to continue to build on that success. So I'll show you a little bit about what the rest of the ORs look like if you want to follow me. So these are basically our 5 operating rooms doing robotic surgery. As you saw, these are 3 cardiovascular units here. And as we keep going, unfortunately, all our robots, all our 4 robotic surgeries are being used right now. So I can't show you in there for patient privacy concerns, but they are being used regularly. A lot of people feel that robotic surgery perhaps is more costly than regular surgery, and why should we be performing it? But the reality is that robotic surgery allows us to, by investing in the best technology, reduce complications, reduce the length of stay of the patient. So the overall cost of care for the patient is actually less when we do a less invasive operation. So that allows us to do what robotic surgery is the surgeon uses these joysticks and these systems that are connected to the patient through instrumentation that is placed on the patient by the surgeon, and the surgeon controls every movement of the machine to make sure that we have a more precise, cleaner surgery. So the operation, as you can peek in here, is done in the dark. The surgeon is looking at a console and at a monitor to look at the anatomy and control this robotic instrument to allow us to do a clean operation, less blood loss, less pain, and a faster recovery. Along that extension, in our oncology program, we have invested in the latest technology for lung cancer diagnosis called Monarch and Ion. Both systems are robotic systems that are guided through the mouth, into the patient's mouth, out into the lungs to biopsy, to diagnose lung nodules or lung cancers earlier. We have that technology available. It's been very successful, and that avoids the need for having to do other more invasive procedures to obtain a diagnosis, and that allows us to take care of the patients at an earlier stage with better chance for a cure. So that's some of the technology that we're investing here at Orlando Health. I think it's a commitment to the best outcomes, leveraging on the innovation available to provide the best care for our patients. Carlos, I give it back to you.
All right, well, I got.
Hey everyone, this is Bridget Key from Community Relations. Carlos is currently tied up doing important business over here, so I'm subbing in to introduce Dr. Herrera, actually, I believe, or I'm sorry, Dr. Walker, or Dr. Kress. I believe Dr. Kress is going to go next. We're having a little bit of technical difficulties for Dr. Walker, so turn it over to Dr. Kress.
Hello.
Sorry.
Thank you, everyone, for giving us an opportunity to talk to you. So I think as everyone had introduced me before, I'm Marshall Kress. I'm the Vice Chairman of Neurosurgery at Orlando Regional Medical Center. I'm also the Director of Neurovascular Services for all of Orlando Health. I think, as people have mentioned, we have a very robust service line across all of the neurosciences, including medical management of brain and spine and peripheral nerve problems, such with neurologists, and then surgical problems with the neurosurgeons. One of the things that I am very passionate about and help lead is our stroke program, specifically our interventional stroke program. So I just want to give you guys a tour of what we do and where we do it. I'm going to put a mask on really quick. So this is our interventional suite. As you can see behind me, we have a couple different rooms, or a couple different arms. And these arms slide into position over the patient who's here on the table, and then we do whatever procedures we need to them with wires and catheters to try to help improve how they're doing. I'm actually going to go ahead and sneak out so they can let a patient in, but I want to take you over here and show you a patient's story. So this is a gentleman who came in and was having trouble moving the left side of his body. And when we came in and did the procedure, you can see here, this vessel goes into the brain. This is a normal vessel on the left side. This is his right side, and it stops right here. So what one of my partners was able to do was to take these small catheters. They're 0.014 inches. So that's a actually this is a 0.021 inch catheter. And it is in the vessel all the way out near his ear in his brain. And the clot is down here. And then he runs another catheter up into that vessel and then pulls that blood clot out. So you can see now, before the blood vessel was cut off right here, and now everything fills past it. So what that allows us to do is to have patients come in, and these patients actually would have potentially even died or needed life disabling but life saving procedures to try to help them live with problems moving one side of their body. And this allows these patients to potentially even walk out of the hospital in a matter of days. We treat about 150 patients a year with that problem. And then we also provide medical services for the other patients who don't need this, but need other things as it relates to stroke. We do carotid endarterectomies where we clean out the carotid artery so that we prevent stroke. We provide medical management and administer medicines to try to keep patients who aren't a candidate for thrombectomy, but can potentially get benefit from other treatments, functional and contributing to their communities. Lastly, we also have a very robust service line across all the specialties in the neurosciences. We take care of spine patients, we take care of patients with brain tumors, and we take care of patients with any other problems kind of in between. So it's a really successful service line for us. We've had a lot of growth, and we've seen really good outcomes for our patients, which is really what makes us excited for us to try to help the people in your community, because I do feel that our patients are better for having an opportunity for us to help take care of them.
I'll describe it. Do you have the mic on?
Hi, guys. Thank you so much, Dr. Kress, for your tour and overview of our neurosciences program. Since the helicopter was coming in when we landed, we wanted to take a quick moment, really live in the spirit of adapting to these times and show you around the helicopter a little bit. So Trey and Miles are going to quickly show us around and take you out on the helicopter.
Yeah, I don't need the glasses to talk. Small number. So good morning. I'm Miles Morgan. I'm a flight paramedic with the air care team of Orlando Health. I've been with them since 2002. I moved from Memphis, Tennessee to do this specific job here with Orlando Health. So welcome to everyone joining in to see all this stuff. It's a great place to work, I believe. We fly 3 helicopters for Orlando Health. We started in 1984 with 1 helicopter and transporting about 100 so odd patients a year. We're up to almost 2.5 million miles accident-free and over 40,000 patients transported in the breast of about 31 years. Last year was our 35th anniversary, and that's a big milestone for helicopter air ambulances. Many of them come and go through the times. Our aircraft has changed over the years. We went from a single engine small aircraft with a small tunnel to load the patients from the rear to a larger aircraft that had no tunnel, now back to a medium-sized aircraft with a tunnel in it. That's specific to our department because of the cases we fly. We also do critical care transport. So we take care of LVADs, we take care of Impella patients, balloon pump patients. The only thing we're not doing critical care right now is ECMO patients due to the size of the machinery and weight and balance for the aircraft. As we fly, we're prepared to do a scene work here within about a 13-county district we can fly to on a tank of fuel and get back to any trauma centers in the area, and all the way back here if need be for burn patients. Also for our critical care medical patients, we've been all the way to the Keys, all the way to Tallahassee for patients, but we normally fly anywhere from about 150 nautical mile radius in Central Florida, which would put us out over the ocean both ways and all the way up to Jacksonville to the north, Miami to the south. That's not unheard of in any given day. Our aircraft is a twin engine aircraft. It's able to lift about 6,000 kilograms gross weight, and then allowing for patient weight on board along with medical crew and the pilot. We fly one pilot, a flight medic, and a flight nurse. The only other specialty team that we fly that's not part of the air care team normally is our NICU transport team, and that's a specialized team that we pick up and transport with their isolette to pick up the neonate babies and transport wherever they may need be. We fly one pilot, as I said, so there's only one set of controls in the front. The aircraft in the rear is set up for one patient transport. We now have 3 aircraft, therefore there's no need for us to transport 2 patients. That would increase the weight of the aircraft, requiring us to carry 2 monitors, 2 defibrillators, and 2 medication sets for everything we might transport. The stretcher's weighted for a 400-pound patient in this aircraft, so we can lift that no problem with any patients we have on board. And we usually fly with about 2 hours of fuel. So that's what our limiting factors for the aircraft are. We load just like an ambulance from the rear. We'll take you around and show you what that looks like. Along with this aircraft, the safety features of flying a EC-135, we have a closed tail rotor for safety reasons that prevents first responders from accidentally walking into it. We always assist our first responders coming to our aircraft when we're trying to load a large patient. In a field down here, we have sugar sand. So a lot of these patients, just like everyone else, their girth has gotten larger and the weight's gotten larger. So we need assistance getting those patients across, especially if they're intubated or have lots of fractures. We load just like an ambulance from the rear. We have a rolling stretcher, so we don't require any assistance. When we go to an outlying facility or on a scene, we don't require the ambulance stretcher to have to come to the aircraft. So we're pretty self-sufficient in that route. As you can see, we load the aircraft down with anything we may need for a scene call, which can go anywhere from motor vehicle collisions to falls. Those are our main calls we run to our critical care transport interfacilities, which run the gamut of cardiac, neurosurgical, stroke. We do a lot of stroke work. As you just heard from Dr. Kress, they have us fly a lot of our level 2 strokes into the facility for care. But we carry enough for at least 1 or 2 patient transports at a time, and then we can restock from this facility at ORMC or at one of our bases. We have supplies. We're located in the area to the south in Kissimmee, Florida, at the airport, to the northwest in Leesburg, and to the north in Longwood. If there's any questions anyone wants to ask specifically about this, I can answer that for you.
Yeah, thanks, Miles. I think we'll we have some time reserved for Q&A at the end. Appreciate you giving us a tour of a small but very important space in Orlando Health. So I think right now we're going to hand it off to Dr. Walker, one of our talented cardiothoracic surgeons, who can talk a little bit about our cardiology program.
Hi, I'm Kaylee Walker. I'm a cardiac surgeon at Orlando Health. This is a pretty exciting place to work. We do about 1,000 cardiac surgery operations a year. We take care of a wide variety of medical conditions, including coronary artery disease, problems with people's valves, problems with their aorta, and also we do arrhythmia surgery. In order to take care of these complex problems, we collaborate with a lot of physicians as well as other members of the healthcare team. We work closely with the cardiologist, the interventional cardiologist, the electrophysiologist, the anesthesiologist, and the perfusionist, as well as the nurses in the ICU and on the floor, and the nurse practitioners who help take care of our patients while they're in the hospital and also in our clinic. Right now, I'm standing in a pretty cool room. It's called a hybrid operating room, so we'll take a tour around. Over here is the heart-lung machine. So this machine we use on a fairly regular basis. It's how we stop the heart in order to operate on it. So we take the blood out of the body, we send it through a pump, it's oxygenated, and then we end up putting it back in the body. So we have access to this machine in this room. Over here, if you sort of move closer to where the bed is, this is what's called a C-arm. And this lets us use live x-ray for when we're doing interventional procedures. So that could be an interventional procedure like what a cardiologist would do, or if we were deploying a minimally invasive valve, or even some vascular surgery procedures are done in this room. Over here in this space is where the anesthesiology team would do their work and help take care of the patient and either manage their airway or their sedation or provide general anesthesia. And then I'm gonna walk around so you guys can kind of get a sense of how big this room is. It's pretty big. Here we have a bunch of supplies in these cabinets. We have sutures here in the event that we need to do surgery. Over here, you can see we have operating room lights, and then there's a big TV screen. There's two of them actually, one here and one over there, so that when we're using the C-arm, we can see how the procedure is going and visualize the inside of the person's body. So on the screen there, we're deploying a transcatheter aortic valve in a patient who's already had cardiac surgery. And the reason why you know that is because you can see the sternal wires here, and here's the aortic valve being deployed. So that's an example of what we do in this room. Good? Are we off? Oh.
Just finished. Hi, Dr. Walker. Thank you so much for that, that tour of the operating room. We had a question come through for Miles about air care, so we're going to step out on the helipad and answer that question for you.
So I'll take you back outside so you can see. One thing that the air care team did early on in 1980s was develop helipad refueling. It was the first in the nation. The question was, what do we do about turnaround flights if we have more than 3 critically injured patients? Besides being able to provide other aircraft in the area that are linked up with our system through our vendor, we can helipad refuel hot while we're either offloading the patient down into the trauma room, or we can have the trauma team meet us up in our elevator vestibule. We can drop the patient off. If we have enough fuel, we'll return to the scene. And anywhere in this area, 30-mile radius, we fly about a mile every 30 seconds. So we can be anywhere in a 30-mile radius within 15 minutes. So we would transport the patient 15 to 18 minutes to the trauma center, turn around, return to the scene. We can be back to the scene within a 30-minute time frame of whenever we're called. So if that answers that question, we can bring that power of all 3 aircraft in. As we land and leave one patient, the aircraft would take back off. Another aircraft can land in this spot, refuel, because there's 2 landing spots, but this is the only spot we can refuel in, is the first spot closest to the elevator vestibule. But we can do that just like an airport, land, lift, and swap spaces and let the other aircraft refuel. So about a 30-minute turnaround, we could be back on scene to pick up more patients. And it's happened in the past. We had a bus crash on the turnpike south of our location, and we transported 11 patients with 1 aircraft off of that scene. So that was when we were doing 2 patients in 1 aircraft. They returned 5 times to that scene to pick up patients. So after the initial first transport.
All right, thanks, Miles. So I think that concludes the formal part of the tour, and just wanted to open it up and see if there are any questions from the group or anything, any additional information we can help with. Anything in the chat?
Nothing coming up just yet, guys, so we're keeping an eye on it for you.
All right, well, we really appreciate everybody joining us today. In addition to what you're hearing from us as far as the services we do, we are very invested in making sure we're providing resources for the business community as you get back to work. If there are questions about these resources, we have a website that Bridget can share with the chamber and then get distributed out, that offers resources about distancing, hygiene, how to any information that you might need or you might want to follow some of our practices around opening up safely. So please keep an eye out for that. And if you have any questions, reach out to the chamber and Bridget will connect you.
Wonderful. We did get another question in, if you want to answer.
Sure.
They're starting to come in here, a lot of them about the helicopter. So if there's only...
Come back. I got to bring a helicopter expert in.
I'm sorry.
Okay, so we've got a couple here. If there's only one helicopter available, do you have multiple vehicles to help transport, or do you make multiple trips? How does that happen?
We could do multiple trips with one aircraft. We do not have a ground component currently. Back in the day, we did have a ground component, but it did not respond as part of our team. Our team has a specialized critical care transport part of the hospital. We're our own unit, almost like an ICU. So we have our own guidelines through our own medical director that's located here at Orlando Regional Medical Center. And what we would do is we would return the helicopter as many times as it takes. This aircraft can fly for as long as it has fuel. And we can return trip back and forth multiple times if need be with one aircraft until another aircraft becomes available. At any given time, you might have an aircraft in Miami, one in Jacksonville, and only one aircraft to cover the area for scene work. But then again, if another inter-facility comes in, we take that call. So we kind of take them as they go. If it became like a mass casualty situation, then there would be the potential for a medical command physician in the ER to help triage what calls we would take. Inter-facilities would probably then kind of take a back seat so we could serve the community for the patients that have not yet seen a physician. So if they're in a hospital with a physician that can care for them, even though they may not have the services, we would want to take care of the patients that needed emergency care first.
If I can jump in. We also have a regional spare here in the region, as well as we have some ground resources for our specialty programs at Arnold Palmer and Winnie Palmer that for anybody that may need an alternate means of transport. And so really within this region, we've got 3 aircraft full-time, 1 backup spare, and then very close to us, we've got additional aircraft through our partner in Air Methods that can bring an aircraft from Bartow or from the coast to be able to provide additional resources.
And that resource from the coast would only take about 30 minutes to get into the area and then transport time back to the facility. And sometimes that is the time it takes for the fire department or EMS to get the patients out of a vehicle if it's a motor vehicle collision. So that's where some of that time can be made up.
So we've gotten a couple chats come in. So back on the helicopter piece, I'm going to try to keep him while I've got him. A couple things I'm going to go through. One was, do you accept other helicopters in from other departments or other regions that are coming in that need the services for the Trauma One Center, correct?
Yes. Funny enough, this helipad is the busiest helipad in Central Florida. We have landed approximately 7 to 8 helicopters not at one time, but just like an airport. We would land 1 or 2, offload those patients. Those aircraft would leave, go to the airport, which is located about 2 miles away from here, to reposition to leave the helipad open. And then they could return and pick up their crews as spaces became available. We would offload patients to come into the facility. So we accept patients from anywhere, from any other providers also.
So maybe you can answer this one. Outside of Pulse, has there been any other mass trauma incidents where you've had to use multiple helicopters, I guess is...
Yeah, and we have that all the time. It's mostly motor vehicle collisions, but we also have a few state penitentiaries close by. And we've had 7 aircraft land at the penitentiary, transport patients from the penitentiary due to a riot situation, and a guard with them. So that means that we had that many people coming in on the aircraft at one time. It was 3 of our aircraft plus 4 or 5 from other facilities. I can't remember if it was 7 or 8 aircraft, but that was a couple of years ago. And it gets quite hectic. That's where our dispatch center is very important to that, because you have someone up here controlling that airspace. If not, you would have aircraft coming in trying to talk to each other about the same time about who's going to be first, who's going to be second. So that helps out a lot. But yes, it's the busiest helipad in Central Florida.
So another one with this, and I don't know if you can answer this one, but I know Randall Park is opening, and this is very concerning to East Orlando, will be opening. Is there plans for a helipad or helicopter landings at Randall Park on the east side of town?
Is that freestanding?
Sure. So it's as a freestanding emergency room, we want to make sure that should we need it, we have access to having a helipad out there. Typically, helicopter landings in a freestanding emergency department based on the way emergency medical services routes patients and where they go. It's typically a very, very low volume helipad and usually does not do a high volume of flights to support an freestanding emergency department. The vast majority of those patients, if not almost all of those patients, will come by ground if they need additional care. And then there's a fairly high percentage that are diagnosed and treated and provided outpatient follow-up.
Wonderful.
I can add into that too. We do not require a helipad to land. We land on scenes all the time that are unimproved. So if you have a parking lot, a space, a grass field, we can land on that too and still do the care. It just becomes a little more difficult when you have a very critical patient that has multiple IV drips or intubated or has a balloon pump on board, and we have to drag that through the grass or do something like that. It becomes logistically more difficult to get that patient transported in a timely fashion. Even though we save the time in the air, if it's going to be a problem with the ground logistics, then we look at that too. But we always go and try to assess the situation. So yes, we don't have to have one. It's preferred. Just makes it easier for the crew to do their job. As you can imagine, while we're doing all this, we're trying to communicate to each other about patient care, but we logistically have to think about everything, weather, what we're going to do, how we're going to get the patient moved, how all that equipment gets moved to the helicopter. And once we get to the helicopter, getting it loaded in to be transported. We operate much like a regular, like aircraft airlines, Delta and all that. We follow those same rules. So anything that goes on the aircraft has to be secured in place. So
while we've got the helicopter, another question came in, but how do you coordinate your flight paths as you're an emergency? So you're flying direct to somewhere. Do you have specific flight paths, and how do you get clearance around the airport?
Right. So we fly GPS direct, and we were the first in Florida to fly GPS direct to the scene. So our dispatch center gives us the GPS coordinates. We put them into our GPS on the aircraft. It draws a line, and we fly straight to the scene. Now, we do also communicate with air traffic control. The pilot's responsible for that because he's the holder of the license to fly the aircraft. So we communicate with them. We go under what's called a medevac status. That's the new terminology the air traffic controllers need to know. Of course, you're not going to move a giant 747 to allow this aircraft to go by. We either fly under them, over them, behind them, because in the aircraft world, it's almost like boating. If you're familiar with boating, the smaller boat moves for the larger boat because it takes more time and space for the larger aircraft to do the maneuvers. We can maneuver very quick. We're like a sports car versus a limousine. So we would move for them if feasible. Many times we do get special handling, and I've had a couple aircraft moved in the pattern to allow us to fly across some of the runways where we go in the south part of the area by the international airport. But it is very rare. There are a couple of hospitals that we land at just off the end of the runway. So we're in constant communication with air traffic control. We have very discrete codes that we use that they know it's us, and they see us flying even before we talk to them.
Great. All right, this is going away from the helicopter, so thank you very much for I think that was a popular one there, as always, I'm sure. So what's Orlando Health doing differently in preparation for patients now in the COVID environment? So are there new protocols, things that you guys are doing in the hospital, and how are you handling that in the emergency departments too?
Sure. So in our emergency departments, we're checking everyone as they come in through the door and identifying those higher risk symptoms, and then we have a section of our emergency room or specific rooms within our emergency room where we bring patients back to that we have a high suspicion of COVID, and then we treat them, screen them, get them off for testing as quickly as possible, and then really treat them based on their clinical presentation. So evaluate where they're at from a overall clinical standpoint and determine what their needs might be. Then, sorry, I had to wake the phone back up. Within our other areas, we have all of our pre-procedural patients are being tested prior to their procedures, and then our team members are being diligent in their self-screening and masking indoors and based on our protocols where they're in proximity to other folks. And then what are other? Oh, we also have our temperature checks at the door for visitors, and we have quarantine unit for those patients that are rule out or highly suspicious or are actually positive with COVID-19. We have a very specific part of the hospital that has ease of egress and entrance to allow for the important care of those patients without impacting the care of our other patients. So we're prepared to be able to take care of those in our community that need care and need necessary treatment, both those with and who are not positive for COVID-19.
All right. We also have here, is it business as usual in the cancer center now that there's been a slowing in COVID cases, or are you still keeping tight controls and limited access to the center at this point in time?
I think I'll defer to Dr. Herrera on that and see what his answers would be.
Okay.
Luis, are you available?
Can you hear me?
Yeah, go ahead.
Great. Yeah, Carlos. So we're taking all the precautions as a cancer center. We're open for business and we are receiving our patients as normal. We did change our protocols in terms of testing, like you said, for all the preoperative patients, but also those patients who are about to receive chemotherapy. Chemotherapy can suppress people's immune system and their ability to fight COVID. So we are taking extra precautions to make sure that those patients are free of the disease before we start, and they're free from contact with anybody with the disease as they undergo treatment. So, but all those precautions are in place, and we are back to almost normal volume within our cancer.
Great. I've got two more questions that are here, and I don't know if this is towards the cancer side, but when do you anticipate, or can you anticipate when you will be able to allow visitors for patients, or will there be something that is dictated by the development of a vaccine when it comes to the visitors to the hospital or to patients that are there?
So we actually never stopped. Well, we didn't stop all visitation. We have a couple of means of visitation available to our patients now. Each visitor, each patient has one visitor, and if we have any significant extenuating circumstances, the exceptions are exceedingly rare, because we want to make sure that we're being responsible with the safety of our community and our patients, but understand that on those very, very rare circumstances, we are looking at each situation individually. But we do allow for one visitor for each patient. That's the same visitor during their stay, in order to reduce the number of folks that the patient and the team are potentially exposed to. We also offer virtual visitation, where we can deploy an iPad to a room and do FaceTime, Zoom, whatever mechanism that the family works best for the family and the technology that they have, so that we can provide kind of an enhanced virtual visitation. And then as far as moving forward, we're really carefully monitoring the data, and it'll be a data-driven decision, and it'll be in concert and consistent with those guidelines from whether it be the CDC or the state government.
And there is another helicopter question, but you may be able to answer this one. It says,
I'll do my best.
How many calls that have required how many calls require a helicopter per year? I know you gave there was a amount for how many over the 30 years.
So we do about 1,500 flights a year, or requests. So the requests come in around 1,900. As you know, in Florida, the only thing that matches the sunshine is the afternoon thunder showers. So we do have to maintain safety for the patients that we're going to pick up, as well as our crews. So we don't fly unless we have safe flight conditions. So we get about 1,900, maybe 2,000 requests, and we fulfill about 1,500 of those, and within the accepted safety guidelines in the industry.
And who determines, just asking this question, who determines whether or not a helicopter does that come in from the ground crew, that first responders that are on the ground?
So there's two elements. The vast majority are either an emergency room physician that makes a request for an interfacility transfer, or an EMS crew that determines based on clinical protocol as well as their judgment what resources they may need to be able to care for that patient. Typically, a prolonged extrication, a significant trauma alert with a long travel time, perhaps bad traffic, those types of things weigh in. And then for the interfacility, it's the acuity of the patient and the physician's certification that the patient needs to fly. As far as whether we do fly or not, that's a decision that's made by the pilot and the crew, and we make sure that we're always able to safely fly and that we aren't taking unnecessary risks, and that we're following all the precautions to make sure that that we're able to help people without creating risk.
Okay, here's another one. It says, I know during COVID we had a lot of, we saw that crime was down and things like that. So are you returning back, or have you seen a difference in your volume in emergency departments, or has it slowed with COVID? Are you seeing a bounce back? How's the flow of traffic to the emergency departments?
Yeah, it was very interesting. It was a pretty significant and dramatic slowdown of folks coming to the emergency departments. One of the things that we did find, though, was the acuity and some of the delays in care were creating a sicker presentation than we would be used to in the past, and we were finding that people were delaying some of their care, and folks were coming in with a more developed set of symptoms. So instead of an acute stroke or a transient ischemic attack or a temporary blockage of vessel, we're seeing people with complete occlusions and significant, more significant presentations.
People waited longer, I guess, to get to the emergency room.
As far as the overall volumes, they were down by anywhere, it varied from campus to campus by a pretty significant amount, half to even more in some cases. We're beginning to see some of that come back. It was interesting that there was even some decline in trauma volumes and other some of the other services that you wouldn't expect to, but it does appear to we're at the beginning periods of folks coming back, and I think part of that is us being able to demonstrate that you can come back safely, and we're ready to take care of you.
I don't know if you can answer this one because it's not really with the ED, but more with, are you getting back up to your schedules with elective surgeries and things? Have you noticed anything with that?
I'll defer to Dr.
That may be not in your wheelhouse.
No, it is. I'm just figuring people are probably tired of listening to me talking.
Yeah, so Carlos, in terms of elective surgeries, we followed the state mandate, and we only did necessary operations during that time to be prepared for COVID. But given that the numbers did not ramp up as we felt it was more important to take care of the patient's needs, and we started to safely ramp up more so now that we have preoperative testing to make sure everybody is safe, and as we perform necessary procedures that were unfortunately held back to some degree. So we're seeing a slow ramp up of all those cases that were pushed back. For example, orthopedic surgery, heart surgeries, cancer surgeries that we're able to wait a few months. We're seeing those being done now. So I would say that we're about 20% off of our volume from last year before COVID. So I think that we're slowly catching up and making progress.
Wonderful. All right. Any other questions coming through? Double check if I missed anything there. Okay. Oh. When do you anticipate going full throttle with elective surgeries? Is that, or is it just a scheduling piece and getting people comfortable to get back?
So I think it's fairly consistent with what you said. I think there's a couple of things there. One is there's a lot of judgment that goes into physician judgment and the relationship between the physician and the patient that go into determining whether a procedure is necessary and needs to get done or not based on the unique presentation of that patient and the skill of the surgeon involved. So as far as bringing it back, we really relied on that relationship to make sure that we were doing those procedures and those surgeries that were necessary, and then necessary and appropriate. And there's also the willingness and the trust and the belief in the patients that it's safe to return to the hospital for those procedures that perhaps they could delay but do need to get done and are necessary. And I think I feel comfortable that we've gotten back to a good place to be able to provide care for both those patients with COVID-19 and those without that need other care.
Wonderful. All right. Oh, one more came in. Here we go. What do you anticipate? Do you have team members that might have received grants to work in the development of vaccines for COVID? Are you doing any research on pieces there within the COVID from the information or data, or are you sharing data with researchers from what you're finding and testing at the hospital?
Sure. So we're certainly sharing our data with the governmental resources, and that gets sort of multiplied across many providers and many researchers that access that data. We're also working with folks that are interested in doing some incidence and prevalence data, but as far as the specifics in the vaccines, those are really being done largely by the large pharma companies at this point.
Okay. All right. I'll give it one more minute here because we are winding down. This has been, I will say, a very unique experience that I've seen, and I thought this went really well. I know we did a dry run yesterday, and I was excited about what we saw from how we were patching in with everybody, and I thought you guys did a wonderful job on this. Some great information, great interaction here, and you guys sounded off and handed off with smooth and everything. This was a wonderful presentation. So I'm going to say, hey, if there's any final words you'd like to say there, if not, I can sign us off there.
I just want to say thank you for letting us virtually visit with you guys. We look forward to those days when we can get back together again and do some tours. But we thought this was a unique way to kind of show you the inner workings of the hospital without making you put on scrubs and walk back into the operating room. And we're so excited to be coming out to the east side of town and be able to offer our services out in Randall Park. And we look forward to being an even bigger part of the community out there. And we really just grateful for taking the time to hear a little bit about our story. So thank you.
Wonderful. No, great story. Hopefully we don't need to see these inner working parts, any of us that are on this call or anybody that we know, but it's comforting to know that the services and these facilities are there for us, that if we come into need, and for our loved ones and family and friends. So I can't thank you enough for being there and being on the front lines for everybody and everything that you do. I can't speak enough personally or professionally about that. I think it's very important. Our first responders are definitely sometimes underappreciated, and you are very appreciated, and we appreciate the engagement with the East Orlando Chamber and getting this information out to our members, as we hope nobody needs to visit there, but if so, the facilities and the tools and the care is there for us. So without further ado, I'm going to say thank you, and thank you to your team. Thank you to all of you for everything that you're doing, and we hope to see you again in a positive note and see people physically and not necessarily always virtually. So we'll see you again, but thank you so much for your time today.
All right, thanks, y'all. Have a great day.
Have a great one, everybody. We will catch up with you on the next one. We've got plenty more planned, so stay tuned to our webinars, and we'll see you soon. Have a great rest of your day.
Other toss-ups, okay?
I think so.